So I'd like to invite our next group of panelists. Thank you so much for joining us. So Tomislav Kamenski, who is Haematology Market Access Lead for Janssen Europe and Middle East. Hi, thank you very much. Kelly Palmer, National Cancer Director for NHS in England and Chief Executive at the Royal Marsden Hospital in the UK. Katarzyna Konechna, by the way, apologies for anything I mispronounce today and tomorrow, member for the European Parliament. Katie Rizvi, co-founder and Executive Director, Youth Cancer Europe. Is Katie here? Just getting mic'd up. So join us when you're ready, Katie. Thank you. Okay, but we'll move into the discussion while we wait for Katie, if that's okay. Let me start. Oh, actually, I wanted to start with Katie. Okay, we'll wait for Katie. It's taking some time. So actually, let me start with you, Callie, if I may. Actually, I want to, because when we talk about innovation, it's very easy to fall into the trap of just thinking about technologies in innovation. And in the notes you've sent me, and I welcome this, you've talked really about service reconfiguration, service innovation. So can we talk about that first? When we talk about innovation for cancer care, how do you see it in terms of the broad service for cancer?
Thanks, Vivek. So just so people know, I have a local role at the Royal Marsden, so I see what happens locally with patients, and then I also have a role as National Cancer Director. And my job in my national role is to drive innovation, to improve access for people and outcomes for people, and just as importantly, patient experience. So probably the example I'll give you on service innovation, I think it is really about challenging the conventional models of the way we deliver care and the ease of access for people across the country. And the best example I can give you of the level of transformation we've achieved is in something called targeted lung health checks. So in the UK, we had, I'm going to talk about England, because I better not do devolved nations, I'm England. That's my responsibility. And we were seeing very high volume cancer, poor survival, very late diagnosis. And so we tried a really small experiment of putting a low-dose CT scanner in a truck in a supermarket car park in Manchester, so north of the country, to see whether that encouraged people to come forward, to sort of risk stratify pathways and speed patients to early diagnosis and treatment where required. And 5 years later, actually it's 4 years later, we've completely reversed the number of people getting diagnosed early when they're potentially curable. And that has led the Prime Minister very recently to announce a national lung screening program. And this was simply about recognizing that we should target the innovation. So we started with sites where there was high levels of social deprivation linked to difficulty with smoking cessation, people not accessing the health service. So we really targeted that intervention, and we put these trucks in supermarket car parks and football stadia where people would be, to make it easy for people to come forward. So when we started, about 29% of people were being diagnosed early with poor outcomes. We're now seeing 75% of people being diagnosed early. So just this change in the model and make it easy for people to access health services and then to risk stratify that pathway has made such a difference. And we've completely reversed late-stage diagnosis for the most deprived in our communities. So we're trying to do more of that by tumour type to really challenge the way we deliver care and give people ease of access.
Great, thank you. I mean, I want to come back and ask some questions there about what it cost and what it needed in terms of resource, etc. And actually, while we're on that topic, I know that, Katarzyna, that the investment aspect is something that you wanted to talk about, is to improve cancer control. Investment, and also you want to talk about IP reform as well. So I'm really interested to understand what you mean by that too.
So I think that, sorry, maybe I start not just in this question, but I think that it's necessary to tell you how is the situation now in the European Parliament as a whole. because we are meeting here at a time when healthcare policies in the EU are awaiting big changes, and not only in the field of cancer care. Currently, there are a number of documents in the legislative process in the European Parliament that will completely remake the healthcare systems in the member states and move them into the 21st century, hopefully for better. And I'm, of course, talking about, for example, the new European health data space, which should accelerate the exchange of health data, not only between researchers, but also between the doctors, and ultimately should accelerate research and innovation. However, the biggest change will be the pharmaceutical package, introduced during this spring. It's directive and regulation for which I'm shadow rapporteur, and after decades of hesitation, they will completely update all pharmaceutical landscape in EU. For innovation, it's first and foremost necessary to completely change the regulation of intellectual property rights, especially patents, as we heard here. However, it's not only about innovation and the competitiveness of our pharmaceutical industry. The most innovative treatment is of no use if it's not available to patients and its access to it's not equitable, as maybe somebody will speak about it here. Unfortunately, this is a major pain of the current healthcare system of practically all EU member states. The equity and access are the key, and it's worth nothing if you have innovative and excellence cancer care, but patients cannot get it or the healthcare system cannot afford it. And the truth is that they can afford is less and less. Those elements are continuous vessels, and we must erase the differences in patients' access to innovative treatment, not only within individual systems, but above all across countries, where there are still deep differences, even within the EU, which is unacceptable, but it's reality in these days. And one side of the coin is, of course, the interconnection of individual healthcare system or a change in the legal framework. The other side is sufficient and sustainable finances. At the same time, unfortunately, access to medicine care, not even speaking here about the innovative care, is member states like mine, is getting worse because money is missing. And in the next EU multi-annual financial frameworks, more money must be decided to the public health policy. If I talk about the money, if you should really be invested in research and treatment and not in the creation of the new institution and bodies like, for example, DG HERA. I'm very open, colleagues, but for me it was a big mistake. Unfortunately, I'm very skeptical in this area, and well, after all, just remember how I went with money for public health policies in the last election period when the current MFF was prepared. And I think that so in this room, sitting people today remember that health was originally not supposed to have its own fund program in the EU budget, and only thanks to the onset of the COVID-19 pandemic that changed it and additional money was found. Healthcare in the EU stands always last in the queue when it comes to money, and unfortunately, taking into account the current aging of the population, the increase in the incidence of cancer and other non-communicable diseases, increased funding is practically inevitable if we want to maintain to least current level of access to healthcare, which is not even good now. This is now situation in EU level. I'm not possibility to heard all speech from Ms. Kyriakides. I don't know what promise you, but in the other side, everything starts with the money. We need to find the money. It's impossible that we start the next period of European Parliament with the same level as it was in 2019, because it was really crazy. And I hope that we find together solution and support what we give it to new Commission, and these support not just you, pharmaceutical industry, innovation research, but so the patients, because I think we never forget for these all parts of a treatment and for medicines.
Okay, thank you. And again, for you, I would like to come back to the specific, after we've heard from all our speakers, the specific proposals that you would suggest for levels of investment, and also that I'm really interested in the IP and patent reform that you discussed. What do you mean specifically by that? But before we come to you, can I ask you, Tomislav, I know for you, Katarzyna talked about access and market access arrangements. I know that's something that obviously is important for industry and for you and for getting medicines to patients. And what do you feel needs to happen in that regard?
Thank you. So first of all, what we are seeing is huge disparity in access among European member states. So current median reimbursement time in European Union is about 18 months. But actually it ranges from 3 months in most developed countries to up to the 2.5 years in some of the member states. And where we see actually the worst situation is in the central and eastern part of Europe and also in smaller member states. So I think we need to work collaboratively to resolve this disparity that's currently happening in the speed of access, but also in the methods and how the HTA bodies are assessing different drugs. The other reason where we are seeing as a reason for delay, obviously when we are delivering new drugs and we have clinical trial results, so many of the assessor bodies are seeing that these data are being immature. So obviously what that leads to is to delay of the drugs to the market or to restrictions of access. So actually we see that on average, 50% of innovative treatments have access in the European Union. And of those, because of the reason I just stated, about 1/3 is restricted to subpopulations or being delayed, right? So we need to find ways in how do we get faster drugs to the market? How do we deal with uncertainty? And is there innovative ways, so like outcomes-based agreement or managed entry agreements, where we could deal with the payers to ensure that the patient gets access to innovation early on?
Okay. Yeah, I mean, that's interesting because taking the standpoint of the payer, of course, they would, from their perspective, it's a question of affordability and financial sustainability. And I think perhaps there's a link back to what Callie's been talking about, because with service reconfiguration, perhaps you remove some of the inefficiencies, which releases money to be able to pay for some of these. So the two are inextricably linked in terms of sustainability. Katie, okay, just a broad question for you, because you represent a patient organization. What's your view on everything we've discussed? I mean, how do we achieve, on the one hand, we've got these wonderful technologies, we've got potential service reconfigurations which require investment. We have a cancer plan which needs to be backed by money and perhaps some regulatory and legal reforms. From a patient perspective, how do we bring these things together, and what do you want to see at the end of the day, and what do you think needs to happen?
Yeah, do I have a magic wand? No. So no. I'm very glad that we are sufficiently depressed in this panel right now, because everything that we've heard so far is really actually quite sad and very depressing. And the reason I'm quite happy about it is because we are a little bit closer to the daily realities of people affected by cancer. Because it is very depressing. However, the task that we were given when we were invited to this panel was to be forward-thinking and not discuss what has been done already, and float on past glories, but talk about some pragmatic and really specific things that actually can crack the code. And I also am very aware that in this panel, or even in these 2 days, we are not going to be solving these massive questions. We're not going to solve money problems. We are not going to be able to do the work that, you know, that is gone into revising the HTA regulations, harmonizing the HTA processes across Europe, or the pharmaceutical legislation and things like that. But I do believe that there are some great examples that might be actually quite low-hanging fruits that can be implemented faster rather than later. And I really do see potential in this. So yes, I do represent Youth Cancer Europe. Mm-hmm. And Youth Cancer Europe has a very ambitious agenda to look at EDI in Europe. Now, EDI, we might be thinking, oh, that's looking at the few, not looking at equity and access for the masses. Mm-hmm. EDI, I mean by equity, diversity and inclusion. And we are doing a piece of work when we're looking at healthcare delivery in oncology for young people very specifically across Europe. And we're identifying areas where they are failed, but we are also identifying good examples. But let's talk about the wider picture, not necessarily, you know, the smaller populations, but the wider picture. There are good examples that might be low-hanging fruit. Banning tanning beds, popular, not popular, it's an effort. The sugar tax in the UK, popular, not popular, it's an effort. Peeing being mandatory every single day for a child going to school in Hungary, popular, not popular, it's an effort. There are examples. So I'm thinking, why don't we have... Sorry. Yeah, that's just me, sorry.
Is it you?
Always. Yeah, it's always me. So there are ways to change things. Changing legislation, changing laws, changing practices now on smaller levels. For example, we know that having young children, for young people juggling a new family, it's very, very difficult. Having cancer, going for your cancer appointment, not having childcare, massive problem. Equalizer, have childcare in the hospital. Not having money to travel for appointments. Ask. Give out some of these travel vouchers, for example, do not cost a lot, make a massive difference. Make sure there is parking in the hospital. So some of these are just strategies. Some of these are just policies. Other equalizers for minority populations, migrants, refugees, to understand how care is being delivered and how to access it. Have it on those languages. Think about those who are might be having learning disabilities or have lower education levels and understand things. These are things that can be done immediately. They will not crack everything, but, you know, and I like to say, we have ministries for health. All member states in the EU have ministries of health. They also have ministries for social inclusion, or at least sectors or departments in government. Is there a person looking at equity and access in the health ministry at the oncology desk? Is there somebody who's responsible for that? Because there are so many good examples already that can be implemented faster. Screening, prevention, having home kits. Why not? In the UK, cervical cancer screening is delivered by nurses. Is it delivered in Romania like that? No. Hungary? No. Bulgaria? No. Why not? It's just a simple way of thinking differently. And these are not huge investments and huge costs. It's just us changing our mentality and putting someone in charge of thinking. So literally, my solution is hire people to think, to get started on some of these things.
Yeah, I mean, it's really interesting what you said, because, I mean, this is all about cancer, but many of the things you referred to actually improve health across the board. And we can't consider cancer in isolation. And in many ways, investments in those basic policy measures, or whatever you want, societal measures, pays dividends, and because it releases, it makes healthcare more efficient, health more efficient, not even healthcare, just keeping people well, you then release money to be available for other things, like some of the innovative treatments, etc. It's kind of an obvious solution. So I want to come back to what makes it so difficult. It's a question to I guess all of you. Well, no, actually, I want to come back to this IP reform question. I really wanted to understand. I really want to understand what specifically that means, because it sounds quite important, patent and IP reform.
So now we have a two-way how to do it. The one we saw in COVID-19, we take the money to the system and for all. But now it's Commission coming is trying to, in a pharma package, is another system. They proposed, for example, longer patents protection for manufacturers who will be able to put their products on all 27 EU member state markets, or a longer period for very innovative products. The problem with innovative medicine is always an access to it, as we heard here, and since usually the price is a change. But what we can do short term in the price are, for example, joint procurement on the EU level, and long term, and this is a now question in European Parliament, what we need to, where we need to find solution and the money is that we have to invest money for relocation and the return back of the industry, especially of the IPI manufacturers back to EU. It's not for 5 years period, it's, but we need to start, I think, yeah, because we saw that without it, it will be very, very difficult to find solution with it. So now we have in a pharma package some parts where we give it something more for pharma industry with IPA, with all these things. But in the other side, in the same time, we need to start with some discussion with our pharma industry, how it's possible to go back to Europe, because without it, it will be the same problem as we had in COVID-19 pandemics or all these pandemics which could come. Yeah. But in pharma package is some type of solution, and we will discussing, and I hope that the Parliament maybe give there something more.
So it's the proposal to extend the IP protection. Right, okay. Any questions from the floor? Well, just obviously put your hand up at any point if you have anything. Ah, yes, we've got one. Yes, please. Can we get a mic over? Oh, here.
Thank you. Thanks to the panel. My name's Kate Allen from the World Cancer Research Fund International. It was a question for Callie, actually. I was interested in the idea of the CT scanners in the trucks, in the supermarkets and things like that. It reminded me of other things I've seen about MRI scanners. And I just wondered, presumably they don't just turn up. I wondered what was around that. You know, was there much of a communication support around that? Or
yes.
What did you have to do to make it work?
Yeah, we've just issued our 1,000th invitation. So we've picked up 2,500 cancers early so far. But there was a big communications exercise working with our patient community and local clinical teams, actually, to encourage people to come forward. So what happened in the early days of the pilot, so we started with this one in Manchester, then we went up to 20, now 43 sites, and now moving into a national lung screening program. But in the early days, we were issuing all these letters and people weren't taking them up. So we had to do a lot of targeted local communications to get people to come forward. So even though the service was easily available, we did have to plan very carefully, because we found there was a disconnect between here's the service in your local community and then here's your invitation and people actually taking it up. So it was a little bit slow on the take-up, but now we've tackled that. So lessons to be learned on how you position when you're doing something completely different. And interestingly, we're picking up not just early lung cancers, we're picking up your point about comorbidities and other diseases. So this model is useful in picking up other conditions where you can fast-track people. But the comms were quite important. And we're going tumour type by tumour type to say, are there similar models? So we've just done one for fibroscans for livers. We're doing BRCA testing for the Ashkenazi Jewish population. So those are much smaller in terms of impact, but nevertheless really important for those patients. So we're trying to sort of roll this model out, but we've learnt on the communication front.
Thank you.
I also have a question.
Yes. Sorry, hold on. Yes, and then there's another person here. Great, okay.
I have a question, two questions, one for Mr. Kamenski and one for Mrs. Konechia. I'm really serious about the disparities in Europe between rich and poor countries. And I'm from probably one of the richest countries, which is the Netherlands, and we do not actually know what to do with our money. So rich we are. But Europe is about free flow of people, capital, and services. That's the fundament of Europe. Now, for Mr. Kamenski, I should say, why not more trials, multi-country, and help at least the people in low-income countries in Europe with better trials? That could be something that industry could pick up. Is that the ideal situation? No, it's not, but it's a start. And for the European Parliament, for Mrs. Konechia, I think free flow of people, capital, and services means also that patients can go for their treatments to other countries where these treatments are available. And if European Parliament or the European Commission says that this is not possible, that is not true, because I'm now helping an organization called NL for Ukraine that brings patients from Ukraine to the Netherlands, to Germany, to whatever rich countries for treatment. So we have started working on this already, and we can do it much better and much more to at least work on the disparities.
Now, was that question aimed at Katerina? Yes. First? Yes, and then, but I think others have a comment on it. Yeah.
I don't know, the first was for somebody else, I think.
Yeah.
Yeah, for me.
Yeah.
Yeah, so I would like to say it's true that probably, the clinical trials in Europe or let's say, the number of patients that we have in clinical trials in Europe is not optimal, and we should probably do better. And in fact, it's been declining in comparison to other regions. So I guess where we are hoping that also, the European pharma package will go in the form of investment, which would also incentivize investment in Europe, and also that we open more clinical trials in more countries.
Yeah, so if I could answer you, it's a very nice question. I'm thinking about it last 9 years, if I am as a member of the European Parliament. But for that, we simply need more powers vested to the EU in the public health policies. That means that we need to reform all the treaties. Without it, it's impossible. Yeah. But if we now had a discussion about the future of Europe, there's, for example, this proposal was not accepted, and I don't know in which time coming on the table. Yeah. But true is that if European Union, European Parliament, Commission, everybody have just some of the part of poverty, it's very, very difficult to find solution, especially for this problem. Yeah. In Germany, for example, because I'm from Czech Republic, yeah, and in Germany, you have, for example, 16 medicines on the market in 2 years, but in the country like Romania, you have just 8. Yeah, and it's a reality in one space, one Europe. And we cannot explain that for patients, yeah? So you cannot simply explain why the patients can go buy a TV and so on. So it's very, very difficult. But without change the treaties, it will be very, it's impossible, I think, in principle. Because every time you meet some Minister of Health from the member states and their opinion, their recommendation are stronger than you and than all EU. Yeah, we just can tell how it's possible to do it. But the systems, the national systems are crucial for this. Yeah,
That's your
I really agree with you, but it's not a question for me. You need to discuss with another MEPs in the European Parliament and with the Commission, and especially with the member states, because there is the biggest problem in the member states. Because if you want to give some competencies from member states, it's something as a Second World War. Yeah, it's really crazy discussing these topics. I understand why. I think that we are preparing for this. I think that we have a support from all the sides. But if member states not will be agree with it, it's impossible.
Yeah. Okay. No. I think we've got a lot of other questions, but I think you can pick this up afterwards. But I get the frustration, and I think it speaks to the highly politicized nature of healthcare. It is, and it's ever been a problem. And I'm not sure what the solution is, and I'm not sure we'll get to a solution here. So if you don't mind, you can continue your discussions after the session. Yeah. Okay. Katie, did you want to say something on this topic, and Callie?
Actually, just basically saying the same thing, that yes, the cross-border health directive exists. Does it work? Doesn't really. National member states still put caps on how many people can access healthcare in another EU country, how much they can afford, because it really is the question of affordability. But also about clinical trials, I just wanted to say that a great equalizer is if there are clinical trials that are designed that can be done in rural centers as well. Because right now, clinical trials are not necessarily accessible for everyone. For example, also transport, accommodation, also for carers, and everything also needs to be part of this package if we want clinical trials to reach more people and more people to be able to participate in them. There are certain things that, again, are currently in the works to change the 18-euro dogma. For example, young people, 16, 17, not being able to access life-saving therapies or innovative treatments or trials because they are not yet of a legal age. And then maybe just one more comment that is actually not only about clinical trials or even screening prevention, but also refers to care. And that's those subpopulations that we have not had the time to talk about so much, but it's something that Youth Cancer Europe is leading the work on and will be publishing and launching a paper on next February in the European Parliament in relation to EDI, is subpopulations like when we look at cancer, at the intersectionality of different experiences, for example, in migrant communities, in refugee minorities, in the LGBTQ community, where either trials or care or certain measures like fertility prevention for oncology treatment is only available for certain people with a certain legal sex. We're not looking at body parts, we're looking at legal sex. That might be different in trans young people. We are not looking at sexual orientation. We don't gather a lot of data. We don't offer a lot of services because we are not trained to ask the right questions when at the places where service is being delivered. We will be looking into this more, but there are certain subpopulations that are absolutely underserved. And as you said it in the UK, you actually made a policy, and you started with one project to see how you can change the numbers by going where people are and reaching those underserved populations. I think, again, hiring people to think in ministries can actually crack the code on a lot of these things, because some of these populations can actually be given more access if we just tweak some things.
Did you want? We've got 2 more questions which I'd like to get through. So briefly, please, and then is it all right if we move to the other questions? Can I give Callie a chance?
Two really quick points, if I may. The first thing is stating the obvious, but I do think that for all the challenges we have in improving survival and quality of care for people, cancer is a brilliant subject for transformation, where you can create a gain for patients and much greater productivity for the funding agencies or the government. So an awful lot of what we're doing in the National Cancer Programme is about survival and improved quality for people, but with a productivity gain. You know, the lung example, for example, that I gave, it means you don't have people going on to complex thoracic surgery, complex drug therapies. I probably shouldn't say that with pharma in the room, but anyway, you know, you're moving the scale. So I think cancer transformation is about productivity gain as well as, very importantly, patient benefit. And just on clinical trials, we run about 600 at any one time at the Marsden. And I agree with Ramon, I think it's about the technical build of the trial, so how you create the trial and the trial criteria, and then how you communicate and manage access to that trial. And we're held to account on that by our national research body, and I think that's really important, so we can demonstrate that we are doing good across the country and beyond.
Really brief, please.
Really brief about the directive of cross-border healthcare, because we should propose to do reform as a parliament, but because everybody knows, I think, that now is outdated, but the Commission did not propose it. So sorry, colleague, it's a reality.
Yeah.
Right, we've got 2 questions and 5 minutes left. I'm getting anxious that we won't get through both. So please, can we keep it brief in the responses and try and keep the question crisp?
Maren White, medical editor, happy recipient of a CT scan in the car park in London. I wanted to, this question was to Katie, and I just wondered whether she could comment on the fact that the EU Commission looked at the paediatric regulation some years ago with an effort to try and change the access for children, actually young adults, and whether 18 is still a sort of cut-off age for children to receive treatment as young adults and not as children, having been denied treatment because of age rather than weight, etc. Thank you.
Right. So I don't think it's a question. It's something that you are contributing with. Yes, it was looked at. I think what is important to recognize is that there will be more work in this space on adolescents and young adults, and it's actually a growing field. Adolescent and young adult cancer care is a growing field where we are contributing a lot, and I hope that there will be some changes as a result of that.
I just wanted to make a comment, actually. I think this is a very interesting discussion. It is about the clinical studies. I'm a pulmonologist. I work in the biggest referral center in Greece for lung cancer, and in my department alone, and there are more than 6 departments, we see about 450 to 500 lung cancer patients, and we treat them every year. So we've tried to be included in clinical trials, and we're cold shoulders by oncologists who, of course, see more patients, prescribe more, and they're more important to the industry. And that's a factor. So that's a fact. So I think we really need to be inclusive, to have multidisciplinary teams, indeed multidisciplinary teams, and have the industry run trials in departments who do the work, irrespective of whether it is oncology or gastroenterology, but actually people who do have the patient and who can do the studies for the best of everyone. And I think that's important. We've tried it with the European Respiratory Society to be included. We haven't managed so far. And I think if we want to look at what's best for the patients as well as for the industry, it is important to be all inclusive.
Okay, great.
Thank you.
We'll take that as a comment. Thank you. Rajan, we do have time, actually. We've got 2.5 minutes left. And sorry, have I missed one? Okay. Oh, okay. Yeah.
Do I have time? Thank you. Rajan Jethwa, Lipsis Pharma. It's a question for the panel on patent reform. I understand the point around extending patent life, and almost every pharma is going to request an extended patent life for their drug. The question I have is, surely that just drives cost at a gross level, and you deny generic competitors for longer. Maybe a better approach would be to look at how clinical trials are funded, taking out time and cost in that process. If you bring a drug to market 5 years earlier because of eliminating the stochastic nature of how trials, most trials are funded, you end up with a longer patent life anyway, marketable, without delaying the approach to generics, but also taking cost out of the system. Question for all the panel, or just food for thought, really?
I mean, it's not necessarily an either or either, is it? Yeah, okay. That's anything to say on that? But I think it's a valid point. Well, we can pick it up in the panel that you'll be on, Rajan, later, actually. Is it tomorrow? We're on the panel looking at investment. So maybe we can talk about it then, unless there's any comments here.
Only just a quick one. So our trials at the Royal Marsden and the Institute of Cancer Research, it's a blended model. Some is commercially funded, some is charity funded, some is government funded, and we rely on that model. We're trying to make sure that when we work with the Institute of Cancer Research, our whole effort from bench to bedside is 50-50. So regardless of whether it's a scientist or a clinician, there's mutual effort involved. But the way we work currently is exactly what you're talking about. It's a blended model, which has worked in terms of being able to get those trials off the ground at speed and deliver results quickly. There we go.
Okay. And there's one on Slido, which I don't want to miss out, and it's a very quick one, and we've got 30 seconds left. To Callie, heartening to hear about success of UK lung screening programme. Is there similar emphasis to ensure these patients then receive the treatment, curative treatment, in time? So you talked about the screening, but now the...
Yes, so the other thing we're doing alongside the sort of early diagnosis strategy is making sure we have something called, sorry, it's a bit jargonistic, but best practice time pathways. So rather than, you get your lung cancer diagnosed at stage 1 or stage 2 in this time frame, in this community setting, we've also got a complete pipeline that says you should receive these treatments or this treatment response within a set time. So we're trying to, there is variation across the country, probably don't need to say that, but by having those best practice time pathways, it's a benchmark for what we expect people to deliver. So we can work out where the gaps are and try and channel funding accordingly. So we're using those to make sure it's not just the front end of the pathway we're dealing with, but we're dealing with the complete, the complete end-to-end pathway for patients, which can be very bumpy.
Great. Okay, and that's us out of time. But thank you very much. I think there was a mixture of depressing frustration, but also I think we did highlight some areas of good practice which could be built upon, and some potential reforms which might help. And I'm looking forward to watching the scrap between you guys outside afterwards as well. Okay, great. Thank you very much.
Thank you.